Good evening, doctors. My name is Ankur Gautam, and on behalf of FDC and Med Talks, I welcome you all to yet another episode of season 3 of Diabetes Essentials with Dr. Sanjay Kalra. Doctors, our today's topic is community intervention and diabetes care. And today's session is brought to you by your zero calorie hydration partner, Enerzal Zero. Now, before giving the session to Dr. Sanjay Kalra, let me announce the last week quiz winners. Dr. Sanjeev Puri from Hoshiarpur, Dr. Surjit Kalsi from Noida, Dr. Bharat Praveen Mitakota from Surat, Dr. Hemant Adikane from Pauni, Dr. Ashutosh Das from Tumluk, Dr. Umesh Kumar Malhotra from New Delhi, Dr. Shashi Khare from Bhopal, Dr. Gangadhar Rath from Bhubaneswar, Dr. Anand Purande from Mumbai, Dr. Shashikant Shende from Mumbai, and Dr. Nakul Bansal from Panchkula. So thank you all the doctors for taking the part in our quiz. Now, to enlighten us regarding today's topic, I would like to invite our host, Dr. Sanjay Kalra, President, South Asian Federation of Endocrine Society. Over to you, sir.
Thank you, Ankur, and good evening, everybody. This is season 3 of Diabetes Essentials. And many of us will think if we've been speaking about diabetes for the past 2 years and still we are not making headway. There are so many things to do, so many things to practice. Why is it that we are not able to get our hands around diabetes? The reason is perhaps we are intervening at the wrong level. Maybe we all think as clinicians that diabetes is an illness of the individual, so we focus on the individual. Maybe that thought process is flawed. Perhaps diabetes is a condition of the community, a syndrome of society. If this is true, then we need an expert in community medicine to help us. And please join me in welcoming one of the experts in this field, non communicable disease public health. Warm welcome to Dr. Madhur Verma. Dr. Madhur Verma is assistant professor at the prestigious AIMS in Bhatinda, Punjab. Warm welcome, Dr. Madhur.
Sir, good evening, and thank you for giving me the opportunity to be here and share my views. Thank you so much.
Thank you. We'll be speaking today about community interventions in diabetes. If you just allow me to share the slides, we'll have a duologue, Dr. Madhur and I, and the slides are visible, I hope, Ankur. Are the slides visible, Ankur, Dr. Madhur? I think they are. So we'll carry on. We'll talk about community. Now, diabetes is a huge burden in India. That we all know. We are all aware of the figures. We are also aware that these figures are just going to worsen and worsen if we don't do anything about it. And like we said, is diabetes as an individual illness? We do a good job of handling that in the clinic. Is it a family condition, or is it a syndrome of society? Many times we feel that diabetes is a family disease. So, Dr. Madhur, is the family a support, or is it actually a cause of diabetes? What do you feel based upon your experience?
Sir, it is actually both. Family history and genetic makeup do define how we are going to behave towards diabetes in our progressing life, and also once you have diabetes, family is one big thing that will help you to decide the future prognosis of the disease. So once you have diabetes, so it is your diet, it is your family environment that helps you to practice better diet and weight management, and at the same time they help you to motivate to do enough physical activity that is important to maintain your daily regime. Further, family is one very important component when it comes to self-care, self-management of the diabetes. So we are going to discuss this throughout the session, and at this moment, family, yes, it is very important, sir.
And Dr. Madhur, can the family also be a victim of diabetes Will diabetes affect only, like in medicine, we say diabetes can cause acute complications, chronic complications, macrovascular, microvascular. Can diabetes cause family complications? One person in the family has diabetes. Can it affect other people financially, emotionally, physically?
Yes, sir. Definitely, sir. Because diabetes is a chronic illness, unlike other infectious disease that we can treat and get cured in a week or two. Uh, but diabetes is a chronic illness and will continue from the day you are diagnosed, and you have to be on medications and lifestyle management throughout your life. So, for normal people who are working and getting access to medicines, it is easy. But for poor people, diabetes can throw you below the line of poverty, and because the out of pocket expenditure can be huge. If it is only oral and glycemic drugs, so the level of the amount is less. But if the patient is on insulin and other management for macro and microvascular complications, the cost can be enormous. And the cost is at the level of individual and at the level of government. So yes, sir, this cost can deprive the children of education, uh, and the cost that was to be supposed to be used for the care of their elderlies, now it is being put to use of the management of the diabetes in the patient only. So it becomes problematic, sir.
So the family, and if you extend it to the community, we represent A is for active opportunity for preventing diabetes, provided that we understand and utilize this opportunity. B is for bystander victim. The family and society, the country at large, like Dr. Verma has said, can suffer from an individual's diabetes because the cost that is incurred on diabetes care is significant, and it is diverted from other things to diabetes management. Of course, the family can cause diabetes because of genetics, because of lifestyle, but then it is a D for dynamic support system as well, because the family does help you come out. If we speak of family, we can speak of community as well. And now we must remember that whatever therapy, whatever interventions we are speaking about, of course, they should respect the individual, the person, the patient. They should be culturally appropriate, but then they should also be collaborative. Everyone should get together. We should bridge divides, and we should get the community and healthcare system together in order to fight diabetes. Dr. Madhur, as a clinician, sometimes I struggle with these words in front of us. So, how do we classify levels of prevention? Can you please teach us? And then also, can you
uh,
give us examples of community intervention for each level?
yes, sir. Thank you for this question. Sir, if we start from primordial prevention, this is something that we start against a problem where the risk factors are yet not present. So, for example, if just to make it very easy, if we are talking about prevention against tobacco and alcohol, so we start talking it to the children in the school who are not yet exposed to tobacco and alcohol. But because the risk factor is not there, they are made to learn that these things are bad for our health and should not be ever consumed. So this is primordial prevention where the risk factor is yet not present. But as the children grow up, they enter into adulthood, and so now their peer groups, they have already, some of them may have already started consuming alcohol and tobacco. Now the risk factor is around them. They are constantly exposed to tobacco and alcohol in their surroundings. So this peer pressure can increase the possibility of these children to consume this substance. So they may be a victim of substance abuse. So prevention at this level, when we keep on educating them with the risk factors around them, this is primary prevention. So this is primary prevention. And now once the patient or the client, they have already indulged into smoking or to alcohol consumption, uh, they are already into the disease. But now we want them to have minimum complications and to leave these abs- abstain from these things. So this kind of prevention is called as secondary prevention, but we are already doing it in our clinics. Like if we encounter a patient who is a diabetic but is constantly having alcohol, so we ask them to refrain from alcohol and and indulge in more physical activity. So this kind of prevention is called as secondary prevention. Now at this the next level is the patient is consuming alcohol. He is now having fatty liver and having liver cirrhosis. At this moment we want that this alcohol should not be minimizing, leading to premature death. So prevention at this level will be tertiary prevention, when the disease has already developed, but we want the patient to have minimum complications because of the disease, and also help him to get rehabilitated back to his normal life. This level is prevention is called as tertiary prevention.
So, Dr.
Now,
Madhur, let us
जी,
look at these levels, four levels or three, if we take primordial and primary together. And let us look at it from a community level. Uh, our unit now is a village of India or a city of India, maybe an urban ward of India. Can
yes,
you
sir.
just list some community interventions that would fit in the basket of primordial and primary?
Say for example, sir, at community level, if we talk about physical activity alone, so if we make a mandate that every housing complex with more than 100 houses should have at least some amount of area, free area, that should be meant for parks and walking. So this
Hmm.
is one intervention that will help you to ensure that you have a better walkability index at the place of your residence. See, when we were young, we had enough space around our houses to play, and that help us to maintain our physical activity levels. But now people who are living children who are living in metropolitan areas, metropolitan cities, so parents prefer their children not to go out. They hand over the video games and TV and YouTube and everything, so that they engage themselves in home only, and they are not doing the actual physical activity. So it is our responsibility to provide our children with better facilities, so that they are having enough uh, physical activity. This is at the level of community.
Community.
Like secondary and tertiary can be done at another level. If a
Hmm.
patient has already developed diabetes, or like who are prone to develop complications, so we have to take care of the things that they are having their drugs. They are constantly adherent to their drug therapy that has been recommended to them by the physicians. At the same time, it is also our responsibility that drugs are constantly available to them. Say for example, a normal patient who is having diabetes non-complicated diabetes, the treatment can range between 500 to 2000 or even more, depending upon the place. So this cost sums up to a huge amount. If the patient is poor and not able to afford the treatment, and the government is providing basic medications as a part of essential drug list, but as long as the drugs are available in the hospital, they are consuming it, what we are seeing in our community settings. And as soon as the drug stock out is there, people leave their drugs. So as a community, it is our responsibility from the government end only, that such drugs should be kept available for them, and they have enough stock, so that these people don't leave their, they are always staying compliant to the therapy.
Yeah.
This is one thing.
So, in where I live in Karnal, we have these beautiful open air gyms. Our
Yes.
parks are equipped with a lot of equipment for exercise, and they're well maintained also by the government and by the public. So, what level of prevention would this be? Open air gyms in an urban or rural settlement.
So open air will help you to will act at a level of primary prevention, because
Right.
looking at the age of the patient. If the patient has yet not developed diabetes,
Hmm.
so that will help him to maintain his weight,
Yeah.
and will
Yeah.
have he will have adequate physical activity, so the disease will not develop. So this is kind of primary prevention. But for an old elderly citizen who is already suffering from diabetes, this will help them to maintain their glycemic levels with enough physical activity. We But sir, open air gyms, they are not people are not very compliant to open air gyms. We have seen, like, we are working with Ambuja Cement Foundation here in Bhatinda, and they have installed open air gyms in villages. But uh, look at a woman, old age woman who is 65-year-old, obese, and had been in her home all through her life. She is kind of having inhibitions in going to the gym, open air gym, and working out. So at this moment, it is important that we as a community should work together and make small social networks. So, like for example, I invite 10 old age ladies of similar age, having, they may or may not be having a disease, and we ask them to sit together for an hour. For 10 days they will have their own gossips, and they will feel at home, and they will make have good connections. But from the 11th day, if I ask them that, why don't you just while you are talking walk while you talk, so they will keep on, they will eventually start walking, and this will increase their physical activity levels, and slowly and gradually this social network can help them to fulfill their physical activity needs. So
Yeah.
community should come together in making better social networks. This thing is not very common in our country, but has been implemented and tested in other developed countries, and they have seen that social networks do have good effects,
So
and
social
it
networks,
helps you to.
yeah, which encourage physical activity, and we are also mindful that social networking is one of the ways which is proven to prevent or postpone dementia. So if you want to ensure
Yes,
good mental health, cognitive health in old age, social networks are very important.
yes, sir, definitely. And sir, we as doctors, if we take the lead and ask our people who are suffering from any disease to come together and sit in the evening, like we have these yoga classes that can be. We have different. Government of India has actually launched a set of exercises for different age groups, and we, being the doctors, if we just ask them to implement these exercises according to their age, so that will help us. Initially it will be seen as a compulsion by the people, but eventually they will love it, and they will be more compliant to this.
Become part of behavior.
Yes sir, yes sir, it.
Now, you've talked of having good uh, healthcare services and also making sure that the pharmacy is stocked. That
Yes sir.
is necessary for secondary and tertiary prevention. At a national level, when our country creates a national list of essential medicines, and the Indian NLEM is actually very praiseworthy because it is very well crafted. And then when our country creates a drug price control, which again is respected and praised throughout the world, what level of prevention is this? We are
Sir, this kind of prevention will be a part of secondary and tertiary prevention, because we are trying to make people adherent to the medications and preventing them from developing the complications. And at the same time, it can be seen as a tertiary prevention, because this will help them to prevent them from the micro and macrovascular complications and become disabled and have die prematurely. Sir.
So what we are seeing is that the community interventions have such a wide spectrum. And when we are working in the OPD, sometimes we get frustrated, we get irritated when we feel that patients don't listen to us. But I
Yes,
think
sir.
if we were to learn from Dr. Madhur Verma and sort of expand our horizons, expand our thought process, maybe we can change the way in which we speak with our patients, the way in which we advise them to do lifestyle modification. So, like now I'm seeing in my OPD, it is easy for me to tell a lady, you must exercise, but I have to create an ecosystem for her to exercise
Yes,
in
sir.
a happy manner. And even if I can't go and create it myself in her village or in her hometown, at least I can give her ideas. This is the way to go about it, madam.
Yes, sir. Definitely, sir.
We have two more words listed on this slide: quaternary prevention and quinary prevention. What do these mean, Dr. Verma?
So these are the extension of the basics prevention level that we have read in our medical curriculum. Quaternary prevention is something that helps you to prevent yourself from over medication. So this will help you to maintain optimal levels of your and also prevent yourself from the side effects that are caused by over medication. The over medication may be because of many reasons, because of the fear and anxiety in the patient that he has developed certain disease and he may soon leave the world. So he would want to stay there because it is a natural thought process. But in this, he may end up in getting the things making things worse.
Yes.
And similarly, this is because of the another level where we hear say many things that may or may not be true. Like during the time of COVID, there were so many interventions that have been listed, that we have seen through internet, that you do this, you do that, and you will not get COVID infection. So this kind of hearsay, if we prevent our patients from this kind of hearsay, from with adequate knowledge awareness and building better knowledge base around the disease that we talk about, so this kind of prevention is called as quinary prevention, sir. So it is important that this is actually, the social media has created a sort of a new term that is called as infodemic, excess of information around us. So whenever you open your WhatsApp, your Instagram, your Facebook, there are so many advice by so many people who may or may not qualify uh, actually to handle that problem, but they have their own set of words. So it is important for us as a doctors to make people better aware about their disease, what to do, what not to do. uh, your one word, your 5 minutes of counseling will go a long way in preventing the complications among the patients. Say for example, insulin only. Insulin, we do agree that insulin is difficult for people who are new to the problem. But if somebody says that insulin has component that is against your religious sentiments, so this kind of prevention would be, and you talk about in detail with your patients that there is no such thing and we are not trying to hurt your religious sentiments. So this kind of information would be part of quinary prevention, sir.
Right. So all these community interventions, but now, Dr. Madhur, a challenge is that the community is so large. So how do we divide and how do we structure? There would be some kind of interventions that are appropriate for the entire community, others that are appropriate only for maybe people of a particular age group, young, middle aged, elderly, and others for those of a specific gender, men, women, transgender. So how do we figure this? How do we work in the community based upon targets?
Sir, to start with, if you are new to the community, what we do is we have a community based assessment checklist. This is a feedback checklist that is meant for people, lay people, that are working at the ground level of our health system, like ASHAs and ANMs. They are not very trained in managing diabetes, but they are good in connecting with the people, and they help us to understand how many people are at risk of developing a problem. Say, for example, this is a basic checklist that will talk about your age, your gender, your residence area, your education, your current occupation, and at the same time, they will ask about if you are consuming alcohol or tobacco, if you are having if you are not engaging in adequate physical activity, you are having high waist circumference. So if you get this basic idea from your community, so you can and also the family history of the diabetes, if it is there. So you get a basic idea how many people are at risk of developing these such disease like diabetes, so we can target such people. So there are two approaches. One is the basic community screening, and the other one is the opportunistic screening. Community screening is what we are already doing in our field areas, with the help of the government staff. We go house to house and screen our people for their blood pressures, their fasting blood glucose levels. So this is community screening, and it helps you to identify the most of it. And the second one is the opportunistic screening. Opportunistic screening is something that is meant for people who are not actually coming visiting the hospitals or the clinics for the purpose that we intend to. Like in a TB clinic, if we have seen that TB has high association with diabetes. So anybody who is diagnosed with tuberculosis and is to be put on the anti-tuberculosis treatment, we can get them screened for diabetes for the duration of their treatment. So such kind of treatment would be, this is opportunistic screening. Another example is pregnant women when they come to your center. antenatal checkup, for regular antenatal checkup. If we get a HbA1c level or basic fasting blood glucose level in the first trimester, that can point towards if she is going to develop gestational diabetes in later stages, but that is to be actually diagnosed at the later stages of the pregnancy. But here you get an idea if she is toward the higher side or the lower side, and we can advise her basic basic life the counseling services that can help her to prevent developing gestational diabetes. And it is said that if you are able to prevent gestational diabetes, so you are able to prevent the late onset diabetes in this such women in the later stages of their life. So this is also part of opportunistic screening, sir.
Mm. So the message I get for clinicians is that if you are new in a community, just do a risk assessment, see what your community needs,
Yes,
and
sir.
then you plan whatever interventions you have to plan. So you have to assess what the community requires, and only then you move ahead. And whatever the community requires, if it is something generalized, then you do that. If it is based upon specific things like gestational diabetes is for women, right? So then you focus on that particular gender. Uh, is it always, Dr. Madhur, that any community intervention has to be led by the public healthcare system, by the government, or can those people in private practice, can they also lead community interventions? And is it possible to collaborate? Can you give any examples, any best practices from India?
Yes, sir. Like I already mentioned about the Ambuja Cement Foundation, they are having as a part of their corporate social responsibility, they have adopted a certain number of villages where they are regularly doing the screening services, and they are um, identifying people who are at risk or they have developed disease. This is just not diabetes, but they are also taking care of other things like high risk pregnancy, non-communicable disease, communicable disease. So it can be done at any level. Maybe it is in government or private, but at the same time we have to also ensure sustainability of such programs. If we are in the private setup or in an NGO, we have to look for the ways in which any intervention that has been started by you is sustainable. If you think you are a single person and you won't be able to continue such things, or if you are able to diagnose such people with diabetes but won't be able to cater to their needs, so you have to link to them to the government health setup, and government health setup is always welcoming such initiatives. Like what when we say, for example, I am going to the community and I see a malnourished child. I may not be able to support his nourishment, the cost of feeding him. But what I can do is I can link him to the nearest Anganwadi center where he can get his basic midday meal that will be able to cater to most of his calories and also a major portion of the daily protein requirement. So such an intervention will be very cost effective at community level and can be also individual taken at up at individual level, sir. And yes, public private collaborations, they are always helpful because they have their own set of benefits, pros and cons. So because they are logistically more sound than compared to the public health system, they can do things which would take time to be adopted by the public healthcare system. So public collaborations, they are also helpful, sir, in different levels, sir.
So one
And
of the
this
reasons,
kind of collaboration we have seen during the COVID times, where so many NGOs have come up forward and helped in distribution and of the oxygen cylinders, food for the migrants. This
yes.
collaboration, this is one example, sir. Sir.
And this is actually one of the strengths of the Indian philosophy, Indian social system. And if there is anything you would like to do, anything any of us would like to do in terms of community interventions for diabetes, just speak out, reach out. Social media is there. Begin telling people what you want to do, what you can do. Talk to people about your strengths. And you will find that this network will grow. You will find like minded people who will involve you in their community interventions. If you want to lead something, you feel that you are capable of being a leader, then at least begin at a small level, and then you will find that more and more people will join you in their in and they will help you achieve your ambition, your goal of improving diabetes care.
Yes,
Now
sir.
in Indian political philosophy, we have two words. One is sarvodaya and the other one is antyodaya. Sarvodaya means benefit for all, And Antyodaya means benefit for the last person in the queue, Antya, the person who is last in the queue. To reach Sarv, that is everybody, and to reach Ant, that is the last person in the queue, we need help, we need ambassadors. So, Dr. Verma, your opinion about this as a community health specialist, what is more important, Sarvodaya or Antyodaya, are both equally important? And what kind of ambassadors can we co-opt or involve in our work to make diabetes care more acceptable to people?
So this is a very important question, sir. To achieve universal health coverage, we actually need to visualize Antodaya. We should be able to diagnose and treat the last person who is in need, uh, and at a cost that is sustainable, because it is not a one-day job that is to be done. And for this, we definitely need help from people. So these people can be anybody. They can be, he can be Amitabh Bachchan, who has helped us to get the
Polio.
vaccination during the vaccination campaign, the universal immunization campaign for our children. He has helped us a lot to get involved and improve our vaccination coverage. But such brand ambassador can also be a patient from the village who is being treated for diabetes, and he is able to maintain his attain optimum glycemic control through the medications that are available in the government setup only. So we can treat him, we can pose him as portray him as a model in the village panchayat only. See, look, this is the person who has been diagnosed and being treated by for diabetes, and he is able to achieve good control, and he is able to maintain his normal life. So ambassadors can be from anywhere to everywhere. That depends upon the needs, sir, and the need at what level we are looking at. If there are certain things, like or like, sir, the study, the diabetes COVID care study, where we talked about the self care practices for diabetes during COVID lockdown. We saw
Hmm.
that people were not adherent to insulin because some felt that it was costly, some felt that it is against their religious belief. So such things do come up off and on. So here we may need to have ambassadors from particular focus, who focus on particular areas, sir. So this can be the thing, sir. Like,
So
sir, in
you,
our immunization campaign, there are certain communities who do not adhere to our recommendations and get their children vaccinated. So we take help of the religious leaders,
yes.
and we preach them. We make them comfortable with our regimes. We justify everything and anything they talk about, and then if once they are convinced, they help us to get other people convinced. And when people from their community talks about adopting a certain thing that is being advocated about, so adherence and compliance becomes even better, sir.
Better. So, like Dr. Madhu said, you can take help from anybody and everybody: philanthropes, public and religious leaders, politicians, celebrities, like he mentioned for the polio vaccination program. And what I've seen in the OPD is sometimes we tend to get irritated at people who speak too much, who gossip too much, who are talking about everything else except the sugar control that you want them to talk about. But these are the very people who speak more at home also, in their village, in their communities, in their mohallas. So you engage them as endocrine evangelists or as glycemic gurus, sugar evangelists. And you tell them while they are gossiping with you, do not get irritated at them in the OPD. You tell them, thank you, madam. I understand that you are so interested in spreading awareness, in spreading the good word. So now that you have learned that taking ghee is bad for health, now that you have learned that eating too much of sugar or jaggery is bad for your diabetes control, please do us a favor and please share this with all your friends in the village. So then you will see when she goes back to the mosque or the temple or the Gurdwara Sahib, she will begin telling all her friends, good or jaggery is as bad for diabetes as sugar is. And then that helps us get the message across. So each and everybody can be an ambassador, and you will find ambassadors in the most unlikeliest of people. Now, Dr. Madhur, speaking of from a healthcare system point of view, uh, what is the evolution of community interventions? Uh, do we still have separate verticals for diabetes intervention? Or are we trying to integrate them with other NCD managements? Or are we trying to embed diabetes care in healthcare, like in TB care, HIV, or maternal child health? What was the policy followed 30, 40 years ago, and what is the policy that is followed now?
Um, Sir, initially, we the non-communicable disease program, it came very late, as the priorities of the government changed. Initially, the priority were maternal and child health and infectious diseases, but we have seen that, because as the government has witnessed that the number of people dying from premature deaths because of non-communicable disease is on a surge, government started implementing more, thinking more towards the non-communicable diseases. It was also into the compliance with the WHO targets that wanted to talk about decreased mortality due to non-communicable disease. Initially, we have seen that there was a separate program for that was for against the cancers, and there was a separate program that was targeting diabetes, hypertension, cardiovascular diseases, and stroke. These three were taken as the initial for the priority list because they had similar risk factors. In later stages, what happened that we actually combined the program for the cancer prevention and the NCDs together. Now it is called as NPCDCS program. So and eventually it is now being also linked with other health programs, like I said that government is making mandatory the testing of glucose in TB patients and HIV patients, and also uh, it is now important to look for gestational diabetes mellitus in women in the antenatal clinics. So it is eventually integrating with other programs, so as to have a more better holistic health coverage, sir.
So this is a evolution that is going on, but gradually, because diabetes is almost endemic now, it is endemic in society, not
Yes, sir.
epidemic, it is endemic. So therefore, you will find that in all kinds of community interventions, in all kinds of national health programs, diabetes care is endemic. So it is embedded everywhere.
One of my senior professors said that anything that is having a prevalence of more than 10% cannot be left alone to be managed by endocrinologists and medicine experts. So everybody and anybody who is dealing with patients have to come forward so that we can control diabetes, the epidemic of diabetes, because at this moment we are now the diabetes capital of the world. And if the same state continues, we will soon be the capital for micro and macrovascular complications emerging because of the diabetes. And it would be really difficult for us in terms of money, in terms of manpower, adequate manpower, who is trained enough to handle such complications. So it will become very difficult. So we have to control the disease in the nascent stages, sir.
And we would like to be known as the diabetes care capital and the diabetes control capital of the world.
I mean, sir. Ji.
uh, if we have to do this, the community has to stand up and the community has to understand that it is their responsibility, not only their right, but it is also their responsibility to take care of themselves. So, our work as healthcare physicians is to offer information, education in a way that is understood by the population. We should also offer facilities to change the way they take care of themselves. For example, offering those parks or opportunities for exercise, offering opportunities for healthy food, and then also offering facilities to improve healthcare seeking behavior. If we can put a primary healthcare center in every village, and we can ensure that that primary healthcare center is staffed with a person who can manage basic diabetes, and the pharmacy also has basic anti-diabetic or glucose lowering therapy. That way, healthcare seeking behavior, healthcare accepting behavior will improve. So, three things that community interventions will focus on. First of all, information, education, knowledge, counseling, support. Secondly, facilities so that we can improve our self care, non pharmacological therapy. And third, facilities so that we can accept and take pharmacological therapy. Now, speaking of non pharmacological therapy, we have spoken about this so often: sensible sustenance, structured physical activity, stress management, sleep management, substance abuse management. Five S's. All of these put together, multi component. So, Dr. Madhur, any best practices that come to your mind? Do we have evidence to show that if we go out into the community and we offer these five S's as a multi component intervention, actually diabetes levels come down or control improves?
So long-term cohorts have actually seen promising results through RCTs and cohort studies that such interventions do help you to control your diabetes level and also the incidence of the diabetes. But yes, this is very difficult in developing countries because of the cost involved. But and so we have to look for things that are sustainable at our level, like what we can offer the patient that is say for example metformin and glimepiride. These are the two most common drugs. But if they are constantly provided to the patient without a lag, so these drugs also can help you to control the most of the cases, and only very few are to be referred to the higher centers for more costlier medications. So it is important, sir. So and at the same time, physical activity and better diet, it is important, sir.
What I suddenly realized while learning from Dr. Madhur is that even within my clinic, even if I do not go out into the community, I am community based, I am community oriented, I am community sensitized. But even if I don't go out into the village, each and every patient who comes to me, who is in a position of power, maybe the sarpanch, I can empower the patient. Now, as a sarpanch who visited me yesterday in the OPD, I did speak to him about diet and exercise. If I had spent half a minute extra, Sarpanji, why don't you share this information with other people in your village? It will be beneficial. If the Sarpanch says I'm very busy, then my request will be, Sir, when you come next time, please bring Madam along with you. Sarpanch Madam ko saath le aiyega. Please bring her. We will talk to her in more detail about food, how to cook food in a healthy manner, so that she can share it with the other women of the village. If I just spend 1 minute extra per these patients, the impact will be many, many fold. And then once I've spoken about sensible sustenance and structured physical activity, then another few minutes I can talk about stress and sleep and substance abuse. So this is something we can do as clinicians as well.
सर ऐसा हमने कोविड के टाइम पे किया था कि
Yes.
बिकॉज
Yeah. In English,
बिकॉज
please. Yes.
हाँ इन इंग्लिश सर
Yes.
हेलो
Yes.
This sort of training in interventions that we tried during the COVID pandemic, where we were thinking of empowering the village people to diagnose and isolate people who are suspected having COVID, and and to help them provide oxygen, basic therapies which were to be kept with the patient. So that helped us to improve isolation and also transmission from one patient to the other, sir. We empowered the people to help diagnose COVID, and then manage them at community level, sir.
That's a very good practice. And if we could do that during COVID, we can do it now as well. So to everybody who is logged in today, very humble request. Let's begin. Let's begin community interventions. How do we begin? First of all, we identify a cause, something that is close to our heart. That is diabetes management. And like Dr. Madhura said, if you are new to the community, if the community is new to you, you just be generalized. Then you identify the community. Whom do you want to target? And then you identify collaborators. They can be people who are coming into your clinic to meet you. Identify them and use them as collaborators. Or you might wish to go out of your hospital to identify collaborators, maybe a religious leader, a public leader, a politician, a celebrity whom you've been treating, anybody. But if we are able to I plan that we are going to begin, then I think we'll actually be able to achieve much better health for all our fellow citizens, for our community members. So a request to everyone would be, please let's begin thinking about the community. When you're in the clinic, in the hospital, in the ward, think community. Just add a few seconds extra, a few minutes extra of conversation to selected people, people whom you think will be ambassadors, and try to reach the community through them. You will find that this will pay very good dividends. Of course, from your practice point of view, but from a community, society, and national point of view. Dr. Madhur, it's been great having you with us. We've learned so many things from you, and you've actually opened our eyes to the limitless potential that we have as clinicians. in managing
I just
diabetes.
wanted.
And
Sorry.
yes,
I was just thinking that maybe to start, we can start from our own clinics. Patients who are coming to your clinic, they may have one or two attendants with them. So why don't we just start with the CBAC checklist that we have talked about to be filled by the caregivers who are coming with them, and we sensitize them that you may be at higher risk of developing diabetes too, like your people, family members who are coming with you. So they may be sensitized adequately, and this can help you to double your effect of being a doctor and sitting in a clinic, sir.
so we
Thank you so much,
prevent
sir.
diabetes.
Yes, sir.
Yeah, and there are lots of questions as well, Madhur. So let's take the questions as well, one by one. And
Yes, sir.
but once again, I think this is one of the most important aspects of diabetes management, and we are continuing with the legacy left to us, bequeathed to us by Dr. K.K. Agarwal sir. And this was Dr. K.K. Agarwal sir's forte, community management.
Yes, sir.
I'm very sure wherever sir is today, he will be watching us, he will be watching over us, and he'll be thrilled at what Dr. Madhur Verma has brought to the table today. Thank you once again, sir.
Thank you so much, sir. Thank you so much.